So today the topic of our discussion is on filariasis, and I am planning to tell you about the overall transmission aspects, the risk factors, and so on. So the lymphatic filariasis, commonly known as elephantiasis, it is one of the neglected tropical diseases. And the infection occurs when filarial parasites are transmitted from one man to the other man through the mosquitoes. And the infection is usually appeared in childhood, causing hidden damage to the lymphatic system. First, I would like to tell you that a brief about the lymphatic system. You are all familiar with the vascular system. But similarly, we have a lymphatic system. It is mainly doing the job of just like in colloquial terms, it's like the drainage of the system from the tissues, and also it is having a defense mechanism. So the immune system is involved in the lymphatic system. Then the painful and the profoundly disfiguring visible manifestation of the disease. You must have seen the different stages of filariasis. That is lymphedema. Then the final stage is elephantiasis and the scrotal in the case of man, scrotal swelling, and lead to a permanent disability. And it is causing mental, social, and financial losses, contributing to the stigma next only to the leprosy. Lymphatic filariasis is caused by an infection with the parasite. It's a thread-like nematode worm. Therefore, it is called. It is affecting our lymphatic system, caused by a thread-like. Phila means thread, and it's a nematode worm, a thread-like nematode worm, causing the damage of the lymphatic system. Therefore, it is called lymphatic filariasis. Yeast means always the manifestation, the inflammation, disease persistence. And there are three types of these thread-like filarial worms. One is Wuchereria bankrupt, you all are aware, which is responsible for more than 90% of the cases, and less than 5% maybe the Brigham Malay, and that is in India. Also, we have mostly in Southeast Asian countries, and in India we have about 6 specific foci are there, and the single largest focus is in the central coastal part of Kerala. The Brigham timori is also one of the species, but we do not have in India. It is in the Timori Island. So these are all the 3 major species we have. The lymphatic filariasis is transmitted by different types of mosquitoes. We in India have only the Culex mosquito, mainly the Culex quinquevaciatus is the vector. Whereas Anopheles is causing the transmission of filariasis in rural areas, mainly in Africa. And the Aedes mosquito also is causing the disease, mainly in the Pacific Islands. And this is the transmission cycle taken from the CDC Atlanta. The adult worms is just I want to make a small mention about the transmission cycle. The adult worms reside or nest in the lymphatic vessels and glands and disrupt the normal function of the lymphatic system. Adult. And the worms can live for about 6 to 8 years during the lifetime. They produce billions of tiny worms called microvilli that circulate in the blood. And mosquitoes, when feed, they take the microvilli along with the blood when they bite an infected individual. And the microvilli further, it undergoes development in the mosquitoes. It will go into 3 different larval stages called L1, L2, and L3. The L3 is called infective stage. So when an infective mosquito bites people, the mature parasite, that is L3 stage, is deposited on the skin from where they can enter the body. And it undergoes further development, migrate to the lymphatic vessels. It undergoes into the L4 and mature stage, adult worm. So thus the cycle, again the male and female mating will take place in the lymphatic system, lymph vessels or the lymph gland. And again they produce the microvilli. Thus the transmission cycle continues. The lymphatic filariasis infection involves the asymptomatic stage showing no symptoms, and the acute symptom, also chronic conditions. So these are all the major conditions when a man is infected with the lymphatic parasite. The major infections are asymptomatic, showing no external signs, and but they are harboring the parasite. Therefore, they are contributing to the transmission of the parasite. These asymptomatic infections still cause damage to the lymphatic system, the kidneys, and they alter the body's immune system. When lymphatic filariasis develops into chronic conditions, it leads to the lymphedema, that is tissue swelling, or elephantiasis, skin or tissue thickening of limbs, and hydrocele, that is scrotal swelling. Here just I want to, next hour you are going to hear from my colleague Dr. Dinesh in detail about these things. Since my topic covers some of the important terms, definition, I think I want to just touch upon these aspects. First of all, the lymphedema. Edema means swelling. So the lymphatic swelling, that is straightforward. Then elephantiasis. Generally, people will have a connotation that it is having a large swollen leg, that is elephantine leg. And people have a perception that it is related to the size, but in reality, it is not so. Actually, the skin and tissue thickening will be there, loss of hair will be there, and it is called a pachyderm. Pachy means elephant, derm means skin. So skin, kind of the elephant skin. What is the elephant skin? Loss of hair will be there, and the thickening of the skin will be there, and that stage is called elephantiasis, and it is not related to the size. It's very important. Of course, the size will be big, but it is more related to the skin. So it undergoes a fibrosis of the skin and submucous mucosa. Fibrosis will be there, and that condition is called elephantiasis of the limbs. And hydrocele, you are all aware that it is an accumulation of fluid in the scrotum, and it's a consequent swelling, that is called a hydrocele. Then involvement of the breast and also genital organ is common, especially in the case of Uchenraya bankruptcy. Whereas in the case of Burugiyamalayi, genital organs are not involved. And acute episodes of local inflammation involving skin, lymph nodes, and lymphatic vessels often accompany chronic lymphedema or elephantiasis. Chronic means prolonged. And most are the results of secondary bacterial infections. You must have seen after the elephantiasis, the nodular formations, nodular or like a cauliflower kind of thing, or many folds, and sometimes the fungal or bacterial infections. And then you have the oozing of the wound and bad smelling. All these are due to the secondary infections, where normal defenses have been partially lost, mainly due to the underlying lymphatic damage, because I told you that lymphatic system is responsible for our defense mechanism, immune system. So these acute attacks are debilitating and may last for weeks to months. These are all some of the photographs taken from our VCRC clinic. These are all mostly taken from the Phrygian filariasis in Kerala. You can see the young girls affected with the filariasis. The first two are the recent edema, RO it is called recent edema. That is when you press the swollen part, there will be a small depression called pitting. It's called a pitting edema. And subsequently, it will become a permanent swelling. There will be a waxing and manning. The third stage that is called a persistent edema. And the fourth, that girl who is engaged in the tailoring, that is elephantiasis stage. And the fourth and fifth one is having elephantiasis with the secondary infections. So these are all some of the definitions or the what is all about acute attack and many things. These are all mainly the source is mainly from the WHO publications I have taken, and you can go through. Just I shall make a passing remark about these things. The one is about the acute attack. Acute always the onset of fever. Whenever there is the worms are challenged in the when there is an edema, then there will be an onset of fever that is called acute attack. There is acute onset of fever with localized pain and warmth, with or without swelling and redness in the lymph or genital area, or also used as a synonym for acute dermatolymphangioadenitis. Acute means you understood that it is onset of fever, and it can be due to the derm, again skin, lymphatic system. Adenitis is a gland, so it is called acute dermatolymphangioadenitis. This is called ADLA. So acute inflammation of the skin and the lymph gland. Then adenopathy is the state of the disease of enlargement of a lymph gland. Then acute filarial lymphangitis. You can very well you'll be able to tell about. I already told you about it. This is an inflammation of what? When the filarial lymph vessel is inflamed, then caused by either by a death of adult worm, which usually produces a palpable cord along the lymph vessel and the progressive dystally. Suppose if you have the lymph node in the armpit or in the groin, then during this stage you will be able to see a streak or a thin red line you will be able to see with the fingers. That is acute familial lymphangitis stage. The chronic manifestation, the clinical signs present over a longer period is called chronic. Then chyluria, it's a state generally seen in pancreatic areas, and it's a chyle is the fatty fluid. Will be seen in the urine, especially when there is a rupture in the lymph vessels, and this got mixed with the urine. That is called the. That time you will be seeing the milky urine. That is called chyluria. Then community-based, home-based care. Home-based care, you are already aware that the informal caregivers in the community will visit the affected people, and they will give you for the patients how to take care of their affected limbs by way of washing. There is a procedure, and so they are called community home-based care. I'm not going into the details of how the home-based morbidity management. Hope my colleague will cover. So I'm not going to tell more about that. Then disability. It is an inability to perform the usual day-to-day work of an individual. That is called disability. And the elephantiasis, I already told you about what is meant by elephantiasis, severe advanced lymphedema and changes in the skin and tissue. And the endemic area in the program, we used to tell endemic area is qualified by the status of the area where the antigenemia or the microfilaria will be more than 1%. It is called an endemic area in the program. And the evaluation unit, especially the study area selected for assessing the transmission assessment survey, is called TAS. You are all familiar. And it may be a multiple implementation unit or be a part of an implementation unit. So that is called evaluation unit. Then like a community home-based care, this is a family home-based care is also there. That is at the family level. The care is given by a healthcare giver with the help of, with or without the help of a family member at the home level. And filarial infection is the presence of either adult worm in the lymphatic vessels or the microfilaria in blood. Hydrocele also, I told you that collection of excess fluid inside the scrotal sac that causes the scrotum to swell or enlarge. Then implementation unit, especially with regard to the master administration, the area defined for the master administration is called the implementation unit. Sometimes it may be a district or sometimes it may be a sub-unit level implementation unit. And lymphatic system also, you know that it's a network of lymph nodes or glands and vessels that maintain the delicate balance of fluid between the tissue and blood. An essential component of the body's immune defense system. And the lymphedema also we discussed, that is a swelling of, edema means swelling. Swelling caused by the collection of fluid in tissue. Mass administration, you are all aware that now we have got, initially we started with one drug, DEC, second we have had DA, that is DEC and albendazole. Now recently in some of the selected districts we have gone for three drug, IDA, that is we are now giving ivermectin, DEC and albendazole in selected districts, and the area defined for that purpose giving this drug is called, we are giving a mass the entire population of an area. That is called mass spec administration. Microfilaria, you all know that it is tiny, the worm, that is tiny worm of the filarial parasite, that is called microscopic larval stage of filarial parasite that circulates in the blood and are transmitted by mosquitoes. Microfilaria, it's a status or the presence of microfilaria in blood is called microfilaria. Then morbidity is again a clinical consequence of the infections. That is called morbidity. Social mobilization. It's also, you all will be familiar with the social mobilization. We use a lot of IEC is given for effective behavior change communication to involve the people for a specific program. Here it is maybe for MDA. So that is social mobilization. Then target population. Always target, there will be a small confusion will be there, but the entire population, we are telling entire population, the strict sense it is not absolute population, it is only the population we are really aiming for, because the some of people like infants, young children, and chronically ill and pregnant ladies are all omitted from the mass spec administration. So ultimately, you will be aiming to cover 85 to 90% of the total population. That is called target population for MDA. And target population for morbidity management, again, the people who are suffering from the clinical illness, maybe the ADLA or lymphedema or elephantiasis or hydrosis. So here, after 2000, we introduced the mass spec administration for LF elimination. But by 2000, we have created a spatial distribution map of filariasis in the country. At that time, we had no classification of the endemic based on the endemicity. Like we have classification for other diseases, but until 2000, we had no classification. And for the first time, we have classified this area into 3 categories. One is hyperendemic, that is endemic level about 10%, and mesoendemic 1 to 10%, and hypoendemic below 1%. So this was the classification we have made while we are making spatial distribution map for the filariasis in India. And that time it was thought that it was an underestimate. The population at true risk was estimated by a statistical approach, and we estimated about 554 million population by 2000. Now the NPTEL has estimated more than 600 million. In 2000 itself, by that time, the NPTEL estimation was about 425 million. That time itself, it was 554 million population exposed to the risk of infection. Then, this is a true filarial endemicity definition was also not available, because endemicity for the program's sake, what I have told you just a few minutes back was the endemicity, endemic area definition above 1% of the MF. But in the true sense, filarial endemicity should be like the incidence of human cases with evidence of persistent local transmission of filarial infection. Because when you tell about endemicity, it's a underlying that endemicity is a local transmission of filarial infection, and that should result in either microfilaria or disease or both. If that is the stage, then it is called endemic, or the status is called filarial endemicity. An endemic area, a geographically defined area with evidence of persistent local transmission of filariasis. This we have defined by year 2005, the definition for endemicity and endemic area for filariasis. Subsequently, we have gone for predicting the areas of risk of infection or potential areas potential for LF transmission. Because we have, you must have noticed in the spatial distribution map, there are some large number of districts were white in color, that was gray, where we had no information. So the unsurveyed areas were assumed as non-endemic. So we wanted to construct a transmission risk map. For that purpose, we have enlisted what are all the likely risk factors that are geo-environmental risk factors we have enlisted. There are some factors, altitude, temperature, rainfall, and relative humidity are the factors directly responsible for the disease occurrence. And there are some factors that they are indirectly contributing to the transmission. And they are called dummy indicators, we used to tell. Vegetation index, land use, land cover, soil types, urban agglomeration, etc. And the other factor is demographic factor. Let us look at it in detail. Here, see, there are three major factors. One is physiographic factors. Second is the climatic factors. Third is the man-made factors. And here, we are going to concentrate on the first two, but we should know what is the third factor, how it is contributing to the disease transmission. First, physiographic, that is altitude, vegetation, land use, land cover, that is responsible for vector breeding potential. Hope you all agree and realize. The second is the climatic factors. One is precipitation, moisture in the atmosphere, plus the temperature and humidity or saturation deficit, together we used to tell. And the climatic condition is responsible for vector survival. So that if you see all the three, then you will understand how the vector breeding potential is responsible for vector abundance, and vector survival is responsible for the extrinsic incubation period. It is nothing but the growth and development of the filarial parasite inside the vector mosquito, that is called extrinsic incubation. The third factor is the man-made factors, population aggregation, movement, solid and liquid waste, change in land use, land cover. So these are all responsible for the post-parasite interaction, the closeness, and also the breakdown of sanitation. And this will result in not only for the vector breeding potential, but also the urban, the industrial, urban agglomeration, industrialization, all these things will come in here. So these are all responsible for the vector breeding and also abundance. So all these three factors are responsible for the disease transmission. And to what extent they are contributing. So we have evolved a methodology for measuring the contribution of each of these factors, and we have evolved a formula for this, that is filariasis transmission risk index. We calculated, and based on this filariasis risk index value, the area was stratified into potentially at risk or no risk. Initially, for Tamil Nadu, Pondicherry, we have developed a transmission risk map that is called a Geo-Environmental Risk Model, or GERM, to identify areas with the risk of of transmission, hepatic failures, saturation. So this we have published in 2006, and again we have validated this risk map, and there was an aggregation of about 93.3% agreeability between our prediction and also the ground reality. That is called the ground truth validation we have made, and the GERM model was found to be a very dependable model, and therefore we have gone for the All India subsequently. And you'll be able to tell on this map what is the population at risk and at low risk. You'll be able to tell more than 70% of the population at risk in the case of Tamil Nadu. You have calculated during that point of time. And these are all some of the white areas I told. We have no information about this area. And with the help of GERM model, we were able to bring out. You can see any area if you touch, then the intensity level will be seen. So this is the significance of this map. Delimitation of LF in India based on GERM model here. And through this model, we were able to tell there were about 190 districts were unsurveyed during by 2010. And by this map, we were able to tell 113 districts under risk zone: Bihar, Haryana, Karnataka, Maharashtra, Orissa, Punjab, UP, Uttarakhand, and West Bengal. We were able to bring out the areas which are likely to be at risk at various levels. Low risk, so many districts; moderate risk and high risk, so many, and 77 districts under low risk. So this means no intervention measures are required here, whereas we needed to concentrate here. And the NPTEL-NOC were partners of this exercise. Therefore, they have initiated line listing of cases in these areas and conducting MF surveys and planning for MDA in all the risk areas. You all know that initially 257 districts have been targeted for master administration. Now the NPTEL-NOC target is 328 districts targeted for MDA. Now, what is the challenge in this LF, elimination of LF? And what is the research agenda? Some of the things we are planning to do subsequently, that is, one is about post-MDA surveillance. We are working on a cost-effective strategy we are developing. An undetected hotspots area, how to go about detection and treatment, and risk, whether there is any risk of resurgence in the past areas. So these are all some of the questions remain unanswered. We are planning to use GERM model and also lymphasim model. My colleague has developed the lymphasim model. We are planning to use these models to address some of these questions. And also we have some more questions with regard to the MF prevalence and sites. At the moment, we stratify the areas as endemic or non-endemic. In the endemic areas, I told you that more than 1% MF rate means endemic. Suppose in a block level, if you will have a different MF rate, and when you go for the district level, sometimes it will get diluted, and as a result, the endemicity level will be low, and you are likely to omit the whole district. But that should not happen. So we have to downsize the implementation and evaluation unit size. And then the task for stopping MDA, whether it is a robust model or we need to do something extra. That is also a question mark. And the task alone is adequate to declare, or we need to have some more measures, because there are the three tasks, first task, second task, and three tasks are there. And all the three tasks passed means now we are declaring elimination of that particular area. But some of the tasks one passed, again it goes failed in the second task or the third task. So we have to go for a systematic, a robust method we have to develop. And we have to also ensure that there is no resurgence occurs after the task is passed, because now we encounter a pass and failure in task. Even suppose after 3 tasks passed, whether there is any guarantee that it will not come back. So these are all some of the questions, research questions, and we are validating these aspects, and we are trying to supplement with zero monitoring. That is, zero monitoring means identifying the infection in vector mosquitoes. That is an indirect way of measuring or detecting whether the area, or finding out the area whether the transmission is there, whether MF carriers are there. So these are all some of the, and it is also proved that the zero monitoring is working well. We have to again give the level, the critical level, then whether this can be used as an adjunct to the tasks. So these are all we are working out. And above all, we need to have the focal intervention and the integrated vector management in all these areas, so that definitely we will be able to stop or prevent the resurgence of the disease. Thank you so much for your patient hearing.